In the first case is a term baby born by elective cesarean for previous section. The non-consanguineous marriage, the parents were of Afghan ethnicity. There are no risk factors in the pregnancy except maternal diabetes. The baby had a birth weight of 3.6 kilo. So as it always happens, it starts as if it's a normal case. So we have a term baby with respiratory distress. We started the baby on CPAP. And then we did the blood gas, and unexpectedly there was a very high CO2 on the blood gas, which was persisting, and the baby had a high FiO2 as well at that stage. So we decided to intubate and ventilate. The CO2 was initially 70 on the capillary gas with the wound heel. The oxygenation was well maintained. The pressure requirement wasn't high at that stage, and the FiO2 had come down from 50 to 25% once we ventilated. But the PCO2 continued to rise. So it went to 90 from 70 and 110 millimeter mercury. So the baby had increased effort and there was retractions despite the intubation. So we decided to give a loading dose of paralytic agent to take out the effort of breathing, and it seemed to resolve the problem. So this was a chest X-ray, which is unremarkable, well-inflated lung fields, ET tube in position, the feeding tube in position. So we didn't have any clear diagnostic clue at that stage. After the baby was paralyzed, the CO2 reduced well, and we had the end-tidal CO2 monitor from the Philips itself, which could be connected, and continuous monitoring of CO2 was available. On that, we noted that as soon as the paralytic, we only gave a loading dose of the paralytic, not an infusion. So as soon as the effect weaned, the baby showed agitation. Then we could see on the sensor, the ATCO2 started rising again. The CO2 increase was confirmed on a blood gas as well. So we wondered what could be the reason. It's not a lung disease, pathology is not significant. The baby is well built and activity levels are normal. It's not a neuromuscular, and of course you have intubated and mechanically ventilated. So despite the ventilation, the baby had a rise in CO2. So we considered possibility of airway related problems. We continued the paralysis as an infusion at this stage, and the CO2 came back to normal. It was maintained, and we discussed with the pulmonology and arranged a CT of the neck and the upper chest. So interestingly, the CT showed narrowing here. As you can see, this is the tip of the ET tube, which was a bit high at that stage, and you can see that just above the carina, you have a segmental narrowing of the trachea. So what was happening is that when the baby is agitated, obviously the increased inspiratory effort and the negative pressure in the thorax was causing the trachea to collapse, and that was causing the absence of gas exchange, or significant CO2 retention was happening. So we were able to overcome this when we paralyzed, and that's how the clinical management was working at that stage. We decided to bypass the stenosis by pushing the ET tube deeper. We measured it so we don't reach the carina itself. So just above the carina, we stopped. And once we did that, we could wean off the paralytic agent. The baby was stable. We started the feeds by tube feeds. The blood gases had no trouble after that. So no sedation, no paralysis, just the ET tube to keep the airway stented at that stage. And because we were not a referral unit, we sent the baby to a referral hospital where the baby was operated. I had the immediate update that the baby did well, but I don't have the details of what procedure was done. So this case was a congenital tracheal stenosis, and it's a potentially life-threatening problem. It's often caused by complete tracheal cartilage rings and absent membranous trachea. So obviously the flexibility is lost, or sometimes the airway cartilage is not well formed, as in this case, it was collapsing. So the collapse could happen either at the site of the stenosis or just beyond that. It's rarely caused by irregular circular cartilaginous plates or disorganized cartilage. This case probably is a disorganized cartilage. Cantrell and Guild classified it as either generalized hypoplasia or a funnel-shaped narrowing or a segmental stenosis, as in our case. So it's usually associated with bronchial abnormalities or vascular abnormalities as well. And the clinical presentation can be mild, where baby may have intermittent stridor or occasional symptoms, or moderate with respiratory symptoms without respiratory embarrassment. Coarse cough could be associated, or severe symptoms like in our case with significant respiratory difficulty. So the diagnosis is typically made by rigid laryngobronchoscopy under general anesthesia. and you can do virtual endoscopy to evaluate the post-stenosis bronchi distal airway anatomy, and HRCT could help to review the endoluminal images up to the segmental bronchi. MRA could help to delineate the associated vascular anomalies, especially, and if there are lung segmental changes, you could pick up as well. And of course, echocardiography is essential as well due to the associated cardiovascular or vascular anomalies. So if the child presents with symptoms suspicious for congenital tracheal stenosis, which is respiratory distress, inspiratory wheeze, and cough and stridor, then you do the echocardiogram as well as CT. And if there is a vascular sling, you think about rigid bronchoscopy if to see associated airway problems. If there is no cardiac malformation as well, you would go to bronchoscopy. And once the bronchoscopic diagnosis is made, you assemble the multidisciplinary team and then decide for the therapy accordingly. Mostly, it's conservative management for the mild cases. Endotracheal stents can be used. Till we transferred, in this case, we use the ET tube as a stent bypassing that stenosis. A pediatric patient can typically tolerate up to 50% narrowing of the tracheal diameter, but remember that any of these babies could decompensate with RSV or bronchiolitis like picture, or the narrowing of the upper airway with nasopharyngitis could complicate because the resistance to the breathing increases significantly, and then they may decompensate with a viral infection. So always warn the parents that if there is a sign of viral infection, they should be extra careful. The surgical options would include resection and primary anastomosis. Could do a patch tracheoplasty, non-tracheal autologous tissue, costal cartilage or pericardium could be used, and slide tracheoplasty, which is a significant procedure. Tracheal transplant is probably not done in majority of the centers. So the slide tracheoplasty is where the trachea is vertically split and you widen it, similar to what surgeries are done in the GI tract as well. So it needs a huge level of technical expertise. I'm not sure if the experts have seen it in their centers. The prognosis depends on the severity, timing of presentation, the nature and length of the stenosis. The milder types have a good outcome. The exercise limitation may happen, especially with intercurrent infections. In the severe type, it's a high surgical risk as well, and unfortunately, not many centers would be capable of doing such major surgeries. So if they are lucky enough to reach a center, they might survive. Otherwise, the severe cases may succumb. And remember that the immediate airway management needs expertise as well, and you may use a smaller ET tube. You may need the anesthetist to intubate such babies as well. So the outcome is improving with recent advances in surgical